Hi, my Gibson Quan Ku, coming to you to talk about the Emerald 2 trial. Quan, talk to us about what you did and what you found.
Yeah, so we designed and performed this study to identify AI-based CT features that can define high-risk lesion for acute coronary syndrome and to prove their efficacy over conventional CT assessment. So we analyzed the CT scan with the patients who had an ACS and happened to have undergone CT scan to define our ability to select the best features of AI-based plaque and hemodynamic analysis and to prove its efficacy to define future corpus lesion for ACS and compare with the conventional CT analysis. So the primary results of our study was that the adding AI-based five best features to the conventional CT-analysis system composed of luminal narrowing and plaque characteristics prove its superiority to predict or discrimination the corpus lesion for ACS. And what is interesting was that we also analyzed as a secondary analysis comparing the efficacy or discrimination ability of sole AI-based almost automatic highly selected features to the best model. And it is interesting to see that that model has a similar performance. And the other most practically important thing we found was that with these models and using explainable machine learning analysis and also time-dependent lesion-specific event probability curve, we can give a clue to the physicians to think about or to extract the best treatment strategy for each lesion. So that's a big difference because that the all previous vulnerability trial can reveal the certain probability, but they couldn't provide the action item. So PCI medical treatment, but although it's still a kind of hypothesis generating stage, but it is great to see that we can provide some clues to the clinicians for their choice of treatment strategy. So that's the kind of summary of our trial.
And Quan, when was the CT performed? Was it performed after the ACS to see if you could predict a future recurrent ACS event?
No, so it's before the ACS. So
Or
the
ACS?
inclusion criteria was prior to 1 month to 3 years, a median
Okay,
interval between CT to ACS were 375 days or almost 1 year.
got it. And so it's very important. I mean, often we look at QFR as the flow as a determinant of risk. But what you're doing is you're saying, no, it's not just flow. The flow may be okay, but it's also the morphology of the plaque. What were some of these AI types of measurements that put people at risk?
Right. So I think that's a very important question. So some are saying that, you know, physiology or hemodynamics is important, and some are saying that vulnerability is important. The beauty of this AI-based analysis is that it can analyze the hemodynamics, luminal narrowing, and plaque burden and plaque characteristics at one time. So we can combine and extract all kinds of information to extract to improve our best ability to predict this future. So that's how we can improve our discrimination or prediction ability for future ACS.
Was this a black box kind of number that arises from the AI machine learning, or do you know which variables it was looking at that, when you brought them all together, predicted risk?
Right. So I think that's another very important question. So there are several. So that we started with the 18 AI-based plaque and hemodynamic features, and through some machine learning analysis and information gain analysis, we extracted five best features, which were delta FFRCT across the lesion,
Hmm.
plaque burden,
Hmm.
total plaque volume, and low attenuation plaque volume, and percent myocardial blood flow. So it's quite interesting that the best selected one represents the hemodynamics anatomic of disease burden and plaque characteristics, and also the lesion location. So those are five features that prove to have the best features to improve our discrimination ability.
Fascinating. What I learned 30 years ago using hemodynamic modeling in coronary arteries was the plaque tend to progress more at areas of low shear stress, but you may have plaque rupture at a site of high shear stress. So, some of these things can go in opposite directions. Well, this is fascinating, Quan. Will this become available clinically to help, clinicians decide which ones to treat, which ones to leave alone?
Yeah, so that's what we think about, and the so we are working more, and the this is the one of the limitation of our study is that the we don't have external control, so we are trying to build the external control models to be really helpful for the clinician. So for example, today we have a patient. I found the seven lesions in that patient, and we don't know what to do except for increasing, doses of statin or PCSK9 inhibitor. But this kind of approach give us a kind of signal that the mechanical treatment or preventive PCI may work in some very high risk patients because if we get to know that this plaque may be a culprit in 90 days, so we can give that kind of information. So that will be very helpful to the clinician to decide their treatment strategy before a set event happens.
Amazing. But, some studies of virtual histology found relationships to subsequent events, but for an individual patient, the positive predictive value, the negative predictive value just wasn't there for decision making on an individual patient basis. So I'm very excited to see that you may have some information that for a given patient would allow people to improve their outcomes. Well, thank you so much for joining us today, and thank you to all those people in the audience listening in.
Thank you.